Good afternoon, everybody. Can we have Tatyal sir, most honorable and venerable senior most eye surgeon?
Thank you so much for a kind, invitation and allowing me to present first because I have to go for the session. I think being a senior person, you require a better visibility to see more better things in a better, clear manner. In that way, we have been very fortunate to have now the type of microscopes which are integrated with OCT. The OCT gives you a opportunity to see things which are not seen through the microscope also. That is what I'm going to highlight in one of the most important surgery in cornea, endothelial keratoplasty. So you can say this is, OCT has become an integral part of our ophthalmic practice. Not only for a diagnostic wise in a clinical OPD setup, it also gives you the plan for a surgical planning, how to execute your surgeries and change your surgical planning on the table also. Because that opportunity normally don't get through the operating microscope. And subsequently, you can monitor your patient in such cases also. So this is one picture that you can see I'm doing a scoring of disease endothelium here. I'm not sure if you've done a complete scoring or not, because the cornea is a little hazier and fibrous. You can see a lot of damage in the peripheral area also. The OCT tells me that still the things are attached here. It's not complete, been scored out the thick adhesive, sometimes you have a fibrous complex of endothelial and descemet complex in these cases also. Unlike in the routine cases, you can peel off very, very effectively also. This is the DSEC surgery has been done. You can see a very nice double ring sign, but I'm not sure if your graft is well attached or not. So people used to do, when we started doing DSEC, we used to put a lot of stromal punctures through which we could drain the fluid out, and we used to wait for a 10-15 minutes thinking that graft would have been attached. So you can see very smooth area, hazy cornea, but see the OCT picture of the same patient, interface fluid is there, which is significant amount. So this tells you that you have to still do a further manipulation to decrease this fluid in these cases also. So this is a DMEC being done in this particular case. You can say roll inside, I'm not sure if the roll is correctly oriented, it is tight or it is open. You can see it's totally, tight roll inside the eye. So your management changes in such cases, and therefore this OCT is of real help in the endothelial keratoplasty. If not only endothelial keratoplasty, all types of corneal surgeries, OCT is very useful, intraop OCT and other surgeries. Like we use this for our retinal surgeries, cataract surgery, glaucoma surgery is being used very, very routinely also. So these are various advantage area. Making the donor lenticule also is very effective because you can measure the corneal thickness or donor tissue thickness very effectively with OCT, which is sometimes very difficult with intraop ultrasonic pachymetry also. So after you make a cut, you can see how uniform thin lenticule have been prepared. And once your thickness is less than 150 microns, then your ultrasonic pachymetry doesn't pick up that thickness. There OCT is very helpful to have this. So these are various areas where it can be useful. Apart from the double ring sign, which is classically described by, I'm not sure who, but described, saying that it is the correct position orientation of graft. The outer one has to be bigger, inner one should be smaller. That means this is the endothelial side, this is a stromal side, because we are punching from the endothelial side, which will be a larger surface. But if you have an OCT, if you can see this sign also, acute bevel sign, this also correlates with the same thing here. The inner area is larger, outer area is smaller, and this acute bevel sign also tells you that your graft is correctly oriented, and this is very useful in the hazy corneas, and you can effectively pick up. The second area of concern for a DSEC procedure was how long you have to keep a pressure inside the eye so that graft gets attached. So this is the study we have done to see how much time it takes when you do a bimanual manipulation, that is increasing the intracameral pressure and massaging from the anterior side. And we could realize in a normal cases, the graft gets attached within the first 3 minutes. So you don't have to wait for 10-15 minutes to see or wait and appreciate the graft is attached. So once you have a clarity of anterior surface and OCT gives you a clear attachment, you don't have to wait. And this will decrease the complication, especially in a glaucomatous cases or a chronic bullous keratopathy where posterior segment can be compromised in these cases also. So this is a typical surgery of cases with DSEC, the graft being prepared, and subsequently we know that how thin or thick graft has been done, and it can be put inside and see that if the graft is attached or not. You can see it's not attached here. We'll do a manipulation and see towards the end it will be attached. So this is the intracameral pressure. You can see with the 26 gauge needle, 28 gauge needle I'm pressurizing and doing a manipulation for anterior side, the graft is well attached. So this bimanual technique is really nice to appreciate how it is being done. This is a DMEC roll being prepared, which is become a simple procedure now, sort of a scuba technique here. We make a large, 9mm partial definition, stain, and then subsequently peel off this by making, addition release. So once you release this, you can easily peel off this membrane by uniform pickup with your forceps, that is a McPherson's forceps, and do almost 2/3 peeling off, create the window, and place the S mark from superior side, and the graft is prepared in these cases also. These are various signs by which you know graft is well oriented. So this is the S mark which is there, or you can see this is Masuris sign, this is Minuteman sign where inner side is colored with the trypan blue dye, and same thing can be seen. So if you have OCT microscope, this gives you assessment inside the hazy cornea, because teaching is if you have a hazy cornea, don't do DMEC, do a DSEC in these cases also. DMEC is more physiological. You can see, I can see the Descemet scoring is complete, the orientation of graft is well oriented, then subsequently inject air and get a better coordinated approach in the surgery for a better attachment. To summarize, OCT is real helpful not only for a diagnostic wise planning your surgery, but intraoperatively it makes things very simple, easier, effective for getting a good outcome for your patient also. Thank you for kind attention.
Thank you, sir. We are honored. Do we have Dr. Jha?
Yeah, it's saved here. Dr. Ujwal. Very good afternoon to everyone. I want to thank the AIO Scientific Committee for giving me an opportunity. So I'm going to talk about amniotic membrane versus tarsography and combined strategies. So we have all come across these tricky situations in our OPD practice. Graft infiltrates, persistent epithelial defects, infectious keratitis, and we're often left wondering what should we do and what should be the right approach. So it's not going to the next slide. Yeah, so a systematic approach helps and starts with taking a detailed history. Good SIDLAM examination with documentation helps, and a microbiological examination by sending corneal scrapings for grams KH staining and culture sensitivity is very helpful in deciding the medical and surgical management. And what are the tools in our armamentarium? I'm going to talk about the first three here: tarsography, amniotic membrane, and the combined procedures. So tarsography has been reported to have 80 to 100% success rate, yet it is quite underused as a prophylaxis and treatment option in treating the corneal surface healing problems. The benefits are it allows more oxygen to go to the cornea, it prevents anaerobic atmosphere, and also retains eye, especially in one-eyed patients. The mechanism is it reduces palpebral fissure, thus decreasing the evaporation of tear film, and promotes epithelial healing. And also the windshield wiper effect is taken care of because of the constant blinking movements of the eyelids. So the indications are persistent epithelial defect, exposure keratopathy, neurotrophic keratopathy, post-corneal procedures, severe dry eye, lid malposition, and post-chemical burns. Now the type of tarsography depends on the location and the duration. It can be temporary or permanent. It can be lateral, medial according to the position of the lesion, and it can be central. Now this is a small procedure, just describe it. So after giving a good local anesthesia, fortunately the video is not playing. Can you play the video, please? So the process basically involves creating a raw area on the intermarginal strip and passing the sutures through a bolster. Now these bolsters can be prepared by an IV set or a scalp vein. We can just pass it from the bolster to the lid margin, make sure that the suture goes through the raw areas and they are well opposed in front of each other. And the sutures are then passed in the from the opposite side, the sutures turned around and then it passes again, and the knots have to be tight so that they're not there's no slippage. Fortunately, the video didn't play. So there are some these are some outcomes of tarsography. Here's a case of HSV keratitis who showed initial response to topical and systemic antivirals, but thereafter there was not much improvement. So a tarsography was done and it showed great improvement. Permanent tarsography can be of great help in cases where there's repeated episodes of stromal keratitis that results in scarring. And this is an old 65-year-old male who underwent the procedure and there was no recurrence for the last 1 year. But not always will a tarsography work. There are some cases where after initial healing, like in this case, this is a case of optical PK where the nasal part was not healing. So in this case, we had to do a amniotic membrane and it showed improvement with minimal scarring. So that brings me to the next part, that is the amniotic membrane. So we all know it's a biological tissue that is helpful in ocular surface reconstruction. The mechanism is basically the growth factors in the amniotic membrane which are responsible for the anti-inflammatory, antimicrobial and antifibrotic properties. Now there are some common indications of amniotic membrane, but apart from the ones in tarsography, it can also be used for pterygium, in OSSN, symblepharon release. We all know it's very helpful in SLED and recently also in retinal disorders like macular holes. I'll not go into the details of preparation, but you need not worry about the preparation part. There are institutes that are providing the tissue, and you also have the freeze-dried membranes. Now here's a short video. I hope this one plays. It was uploaded separately. Can you play? Can we go to the next slide? Yeah. So again, amniotic membrane is very helpful in non-healing ulcers. This is a case of a one-eyed patient who underwent the procedure, and also the important part is that it helps in reducing the scarring. This is the case of amniotic membrane for SLET. This is a two-stage procedure done for a chemical injury patient. He had first undergone symblepharon release with amniotic membrane, and then 3 months later, a SLET was done, and there was some partial success. Now there are some techniques, there are some indications where we have to do a combined procedure, such as when there's an infectious keratitis with high risk of perforation, severe chemical burns, non-healing ulcers with stromal melt, acute SJS or 10. So in these cases, such as these, there was a large ulcer with endoexudate which did not resolve to antimicrobial therapy. Combined amniotic membrane with tarso was done, and there was scarring and healing in this case. The culture showed pseudomonas in this case. Here's another case of a HSV stromal keratitis that showed great improvement after 3 months. Sometimes we don't have the amniotic membrane at our disposal, and in these cases, the option is a Tennant's patch graft, which can be very well helpful. This is a case of a graft infiltrate, which also had thinning. So a combined procedure was done, and at least it saved the eye, and we were able to save the globe in this case. So what does literature say? There's not been a lot of study comparing amniotic membrane and tarsography, but this is one case where one study where they found out that tarsography was slightly superior in terms of pain relief and in the healing time for the epithelial defects. But this study only included persistent epithelial defects. They did not have other cases like infectious keratitis or non-healing ulcers. So to summarize, tarsography is very cheap and cost effective. The benefits are that it has long-term protection, and amniotic membrane on the other hand is costly. It needs a membrane that has to be sourced. The benefits are that it has anti-scarring properties and also provides mechanical support, especially in cases of stromal thinning or impending perforation. And combined procedure is very helpful when you have a non-healing ulcer with a high risk of stromal melt or a large infectious keratitis, which is likely to perforate. So the take-home message would be both of these procedures are valuable options in treatment of corneal diseases. The choice of procedure depends on the etiology, location of pathology, and the resources at hand. And combined techniques obviously offer enhanced benefits. Thank you. Fortunately, the video didn't play.
Thank you, Dr. Jha.
Yes. thank
Any
you, sir.
questions, please? Can I make a suggestion?
Sure, sir.
Kindly reduce the number of lines per slide.
Pardon me, sir?
Number of lines.
Right, sir. Thank you. I'll keep that in mind. Thank you, sir.
Can we have Dr. Tarannum, please?
ये नहीं है, खुद करना है, मुझे करना है, मुझे करना है खुद से।
यही है
ये वाला Good afternoon, everyone. So I will be talking about tissue glues in corneal perforation. So corneal perforations, they are ocular emergencies which as present they are being managed by various conservative measures like BCL, tissue glues, sutures, as well as permanent measures like DALC and PK. These sutures have their obvious disadvantage in the form of long surgical and healing time, risk of infection, scarring, and astigmatism. Now, tissue adhesives, they cover most of these disadvantages, but whatever tissue adhesives we are using till date, they have disadvantages of their own. So we are yet to find the ideal tissue adhesive, which has to be cost effective, transparent, easy to apply, biodegradable, biocompatible, should set rapidly, provide healing enhancement, in situ cross-linking, and should also have post-operative comfort. Most importantly, it should be a strong adhesive to the naturally moist ocular surface, because most of the tissue adhesives, they require a dry ocular surface, which is difficult to achieve. Tissue adhesives are broadly divided into biological and non-biological, which we all know. But the most commonly and the oldest tissue adhesive which has been used off-label is cyanoacrylate glue. It is ideal for perforations which are less than 3 mm in diameter, concave in profile, and away from the limbus. It is having additional advantage of being bacteriostatic and disrupting the stromal melting. So that's quite an important point. So this is how the healing happens with the cyanoacrylate glue post-operatively. Now, the newer derived longer alkyl side chain derivatives of cyanoacrylate glue, they have additional advantage of being more biocompatible, that is less toxic, but their tensile strength and bacteriostatic activity is less as compared to the shorter chain derivatives. Now, as far as the technique of application is concerned, for smaller perforations, the routine we can do, just we have to ensure that the field is dry and a small amount is applied through a 27 gauge needle. That really helps in putting a small amount, and initially apply a thin layer. If required, you can repeat. For larger perforations, technique 2 is recommended, that is the drape technique, gluing a disc of sterile plastic drape, which is going to help you with creating a barrier between the anterior chamber and the glue. Then there are certain variants of this technique. One is the 10-0 nylon suture mesh is being created between the over the perforation, and over that the glue is applied. But again, that can be little surgically tedious in a perforated eye. Double drape technique is also being advised for larger perforations to create that barrier. Then there is this scleral patch graft augmented. Instead of drape, here you are using the scleral patch for the creating that barrier, and along with that the cyanoacrylate glue is applied. This technique helps in non-infectious corneal perforations where the melting in the periphery is continuing, the disease process continues. So in those cases it is really helpful, and it can work even for larger perforations like 3.5 to 4.5 millimeters. So this is how this scleral patch augmented technique works over these peripheral sterile perforations. Complications are mainly related to its toxicity, causing stromal, endothelial, and lenticular toxicity. IOP can also rise because of inflammation of the trabecular meshwork. An infection mainly related to the prolonged use of BCL, which is very much avoidable. Then there is another synthetic adhesive, which is the PEG, which is polyethylene glycol based, which is safe, well tolerated, elastic, biodegradable. Disadvantage is it is not appropriate to function as a stromal filler. It requires a completely dry surface. For a opposed surface, it is doing fine, but when there is loss of tissue, so there that poor mechanical property is going to come in way. Then comes the biological option, again commonly used, that is the fibrin glue. So it is completely biodegradable with very less toxicity. So for defects up to 2 millimeter, it is as effective as CAG. But the disadvantage, it degrades more quickly, it does not have antibacterial properties, and has the risk of transmission of the viral disease. Now this infection part can be controlled by various measures, but the safest would be to prepare the fibrin glue from the patient's own blood, so that factor can be very much controlled by this particular option. Technique of application, it can be applied simultaneously. For that you need to have a duplicate syringe, or that completely depends upon the surgeon preference. And then there can be a sequential application where you apply thrombin first, followed by fibrin, so that can be identified as a thicker and thinner component. You have to explain it to your technician. So this is just a comparison which we have already discussed of the two commonly used glues. So as we can see, all the glues have the advantage but disadvantages as well, so we have to pick and choose. But the clinical need for a fast curing strong tissue adhesive is still remains unmet. And various polymers, they have been tried, of which this gelatin is a promising biomaterial considering its availability, cost effectiveness, water solubility, and presence of cell binding sites and metalloproteinases. So this basically, it works in situ within 2 minutes using the UV light and a riboflavin sodium persulfate system. It has shown to fill the corneal wounds and restore the corneal curvature and providing a very smooth surface. And its burst pressure is comparable to CAG, transmittance, water content, and storage modulus similar to the normal human cornea. So this is looking quite promising. So these are the properties of Gelma bioadhesive, and this is how it works. So I will be just winding up. These are the other options other than glues that you can, you have in-house, and you can always use that, flaps and AMG if it is available, and Tennant's patch graft, that also is quite helpful. But when you are not, cannot, resort to any of these measures, you have to go for keratoplasty procedures, which can again depend upon the size, location, and cause of the perforation. So take home message from my side, management of a corneal perforation depends upon the size, shape, location, and very importantly, the cause of the lesion. Smaller lesions can be, managed with tissue adhesives, Tennant's patch graft, AMT, but larger perforations need urgent keratoplasty. Number of new adhesives currently under research, but long-term trials are definitely required still to establish their efficacy. Gelma bioadhesive seems to be a promising option. Thank you very much. Thank you for your patient hearing.
Nice presentation, ma'am. Have you used? Thank you.
Is Dr. Shefali here? Dr. Gunjan? Yeah.
So at the outset, I would like to thank AIOS for giving me the opportunity today to present. So I'm talking about the dry eye management. So what is the role of inflammation? First, we have to understand what are the key mechanisms of dry eye. So it's a tear film instability, hyperosmolality, causing cell damage, apoptosis, nerve stimulation, and then turning out to be inflammation, and MMP activation that leads to goblet cell loss, and in turn tear film instability. So MGD also does the same job in this kind of patient. So there is a whole lot of array and spectrum of these kind of disorders that cause these issues in the dry eye disease. So ocular inflammation is a physiological response to the invading pathogens or antigens, and it is due to infection or injury that can result in ocular inflammatory diseases, mainly allergy, conjunctivitis, dry eye disease, scleritis, keratitis, uveitis, etc. Excessive immunity response can also damage the healthy tissues, and this can affect parts of the ocular system that become tender and inflamed. And also some patients may have visual loss in chronic or severe diseases. So the consequences basically are dependent on a tissue destruction and also the neurosecretory block, which are mediated by the immunocytokines, and this may cause chronic neural damage as well in these patients, which can lead to reduced reflex tear secretion, loss of sensory drive to the lacrimal gland, and also decreased corneal sensitivity, leading to the secondary dry eye. So these levels are definitely dependent on various NGFs and CGRPs, and they also cause severity of the dry eye disease. So as I already talked about inflammation, there are some immunological disorders like Sjogren's syndrome as well, and aging sometimes also plays an important role in these kind of patients. Environmental factors are important in cases of air damage and also in allergies in such patients, which can cause a whole T cell activation and infiltration. Then there's an influx of calcium into the cells and all the mechanisms that can cause inflammatory mechanisms which increase the activation of cytokines. So we can see here, which I already discussed in the previous slides, that this can cause apoptosis and stimulation of the secondary growth factors and neurosecretory block. And MMP9 is a very important parameter in damaging the ocular surface in dry eye disease. And nowadays we are getting a lot of MMP9 strips to find out dry eye in such patients in our clinics. So they are secreted at high levels by ocular surface epithelium in patients with dry eye disease. The consequences of this inflammation also causes positive feedback loop of inflammatory mediators, and this continues the inflammation. So as we look in the healthy eye, we can look at the dry eye disease. There's a whole lot of increased cytokines and various other modulators that damage the ocular surface. So the patients that come up with these kind of symptoms are having stinging, dryness, blurring, grittiness, crusty lid margins, redness, epiphora, foreign body sensation, which can be exacerbated by increased tear evaporation in wind and air conditions, and also they are exacerbated by prolonged breathing, which causes decreased blinking mechanism in these kind of patients. So how do we diagnose these inflammations? First, we need to find out the patient on examination on a slit lamp, what is the response, what are the different therapeutic approaches that may cause indication and inflammation in these kind of patients. So we have to do a whole array of diagnostic tests, and we can also have to look around all the external signs in these patients, and TBUT is also an important parameter in such patients, and NIBUT is also there. Staining is a very important part in these kind of patients. Schirmer test we can do in our OPDs, and MMP9, as I discussed, there are strips available in the market which now we can look on in these kind of patients. Impression cytology is a doable exercise, but it's not very commonly done in our clinics. The standard therapies are important because patient education forms an important role in computer-related vision diseases, and also various environmental dietary modifications may help in Sjogren kind of patients who are having immunomodulatory diseases. So patients with moderate to severe dry eye should be considered for anti-inflammatory therapy with a whole array of anti-inflammatory therapies, which are cyclosporin A, corticosteroids, oral tetracyclines and macrolides, omega-3 fatty acids, but we have to be very sure of getting not into the overdose kind of spectrum. So as I discussed, corticosteroids, tetracyclines and macrolides have significant risks which are associated with long-term use in these kind of patients to address the inflammation. Cyclosporin A forms an important role which has been approved by FDA in 2003 for treating patients with dry eye disease. The potential mode is the inhibition of the T cell activation, and the primary mode is to bind to the cyclophilin and causing calcineurin not to be activated and in turn immunosuppression. So there are various formulations that come into the market, which is restasis and also other things that we can use in such kind of patients. So we have seen improvement of the signs and symptoms of disease in these kind of patients at all severity levels, and they form the decreased in, so they help in the treatment of dry eye disease in such patients, and this has also been proved over the literature in past things. So there is a comparison of cyclosporin 0.05 which improved the dry eye symptoms over 6 months. So long-term safety parameters have also shown safety of this drug through the blood levels, and no detectable levels of cyclosporin have been found in the systemic absorption. There are a lot of adjunctive therapies as well, like topical steroids in mild quantities and for longer and for shorter durations. So these are quickly, I'm just going over the summary. The inflammation is one of the 4 key mechanisms of dry eye disease, and stimulation of inflammatory mediators, especially MMP9, and there are a lot of therapies for treating inflammation, including artificial tears and cytokine inhibitors, and cyclosporin A is effective at reducing the signs and symptoms of disease. Thank you so much.
Thank you, Dr. Gunjan.
Thank you, sir.
Dr. Sonal is here.
So the topic of my presentation is complex Descemet stripping endothelial keratoplasty. So DSEC is pretty straightforward when the iris lens diaphragm is intact. Either a crystalline lens is present or a well-centered PCIOL is present, because it offers resistance to the air bubble that we place at the end of the surgery. But if this diaphragm is compromised, then that effective tamponade is not possible, and chances of graft dislocation are more. For example, patients who have PC rent or vitreous in AC, we need to do a concomitant iris claw, SFIOL, or there is a functioning glaucoma valve or trap which provides egress to the air that we put at the end of surgery. Also, presence of peripheral anterior synecdoche and shallow AC also make the surgery a little tricky. So ideally, if secondary IOL is to be done in patient, then DSEC and IOL implantation should be done in 2 settings, at least 1 month apart. However, sometimes it's not possible, and we need to do it together. In such cases, the problem arises is because the eye tends to be on the softer side at the end of surgery, that effective air tamponade is not possible. So no matter what we do, the tight airfill that is required after putting in the graft is not possible. There are certain things which we can do to enhance the success rate of our surgery. That is, instead of keeping that air bubble for just 10 minutes, we should put it for at least an hour. And a good surface massage is also very important, because if there is no interface fluid and the graft starts working and starts absorbing the fluid, then it tends to create a sort of suction and the graft sticks to the host. Another thing that we can do is that we can use C3F8 or SF6 non-expensile mixture, which provides a longer tamponade as compared to air. So poor visibility is expected. However, sometimes we need to do some extra maneuvers inside the eye, like seeing how the IOL is there. So for those cases, apart from doing an epithelial debridement, we can use a light pipe during those crucial steps. And the second thing which I have found useful is that filling the anterior chamber with air bubble for some time also leads to reduction in stromal edema temporarily, and for those crucial steps, the visibility is enhanced. So descemetorrhexis should be ideally done under air, because the visibility is very good. Also, if there's any vitreous in disguise, then it shows. We can see pupillary peaking, and the air bubble will be dimpled on some side. So it is better that we put an air bubble and then see what is inside the eye. If we feel that the eye is not going to be very stable during surgery, we can use a anterior chamber maintainer for performing the rest of the steps of the surgery. Phacoemulsification with DSEC is actually simpler than what we would think it would be. Once a continuous curvilinear rhexis is complete and we have done the nucleotomy, we can prolapse pieces in AC. The endothelium is already compromised, we need not worry about it. All we have to take care is that the PC integrity is maintained. The rest of the surgery is like that of any simple DSEC. So if the AC is shallow, I would say that DMEC would be a better option because the graft is thinner. We should do a PI so that there's no risk of pupillary block, and we should use a smaller graft. And every attempt should be made to release the peripheral anterior synecdoche because that will help us use a bigger graft, and also it will not threaten the immune privilege of the cornea. So pupilloplasty should be done wherever possible and needed. However, in some cases, it is not possible. The iris is very floppy. It's beyond repair. In these cases, like for example, in this case, when I inserted the graft, the iris got in between the donor and the graft. So gently nudging the iris away from the graft, taking care that the endothelium is not touched, and then we put a small air bubble and suture all the ports, and then in the end, instead of a cannula, we use a 30 gauge needle to help keep that iris away from the graft. This is the post-op picture. If there's a functional trab or glaucoma valve, plugging it with viscoelastic before air insertion also prevents air egressing out of the eye. This slide I have added because it was an interesting case of a bee sting injury in which there was a pericentral sterile infiltrate and scarring, and the DSEC worked well for this patient. This is another patient in which we think that patients who have any bit of stromal scarring will not do well with DSEC. It is not true. If there is anterior stromal scarring, then DSEC works well. It takes time for cornea to clear, but it works. So this is a photo showing pupillary block. We can do burping, or actually in this patient the PI was not very peripheral as it should have been. So if it happens, we can either do burping or ask the patient to slightly bend and keep his head towards his knees in regular intervals so that the air is able to move in the anterior chamber. So in the end, I would like to say that decision making and patience are required in complex DSEC cases. Thank you.
Thank you for finishing in time, Dr. Sonal.
Can we have Dr. Rishi, please? Dr. Rishi is a distinguished and accomplished eye surgeon.
Thank you, sir. So after those lovely DSEC videos, we'll move on to DMEC, and then I think we have a talk on PDEC also coming, so all the endothelial keratoplasty options will be covered in this session. So I've tried to keep this very simple and tried to kind of just cover all the basics and not avoided the advanced scenarios, etc., because DMEC is still gaining acceptance and it's still a difficult technique for many, and many people are yet to start their journey on DMEC. So, it's basically targeted towards beginners, this talk. So endothelial keratoplasty has been evolving. It went through posterior lamellar keratoplasty, which was introduced by Dimitri Azar, in which he made a LASIK flap and then he did a trephination on the bed and then sutured another lamellar endothelial graft and then put the flap back. Then there was DLEC, which was introduced in which we would, it was like a precursor of DSEC, in which we would actually kind of do a lamellar dissection in the cornea and then cut out a small disc from the anterior chamber and replace it with another disc of stroma and endothelium. Then DSEC came, which was a manual dissection, which we know about. Then DSAEK, in which we use a microkeratome to do the cut of the cornea. Then DMEC is the desmoid membrane endothelial keratoplasty, and PDEC is pre-desmoid endothelial keratoplasty, in which we take the advantage of the Duas layer, and that will be covered by my subsequent speaker. So it's a revolution in evolution, and my preferred technique is the DMEC, and I will just tell you about it. So why, first of all, why do many people not do DMEC, or why should one not do DMEC? These are the reasons you could state. It's a difficult learning curve, higher surgical time, lack of high quality donor tissue, paucity of tissue, lack of standby tissue. Young donors, 45 or younger, sometimes we get very tight scrolls which are difficult to open. So it may be difficult to use these tissues, especially in the initial cases. And increased need for repeat procedures like rebubbling. So, you know, in private practice, etc., it's difficult. And it has a significant learning curve, so risk of complications is there. But once you're past that learning curve, actually, it becomes pretty repeatable. So why should one be doing DMEC? A lot lower rejection rate, faster and better visual recovery, more patients will get 20/20, and better understanding of surgical nuances over the years has made the procedure more repeatable and predictable, and that's the idea of this talk. So donor selection, avoid too young donors, avoid diabetics, avoid donors with fellow eye DMEC harvesting difficulties. So if one eye has had a problem, then don't use the other eye for a DMEC, use it for a DSEC. And of course, we want an endothelial count more than 2,500. Diabetics, the DMEC tends to, the desmoid membrane tends to tear while we are trying to strip it. In the initial cases, avoid patients where you can't see very well, so stromal scarring, etc., or post-grafted eyes, very deep ACs, aphakic eyes, post-filtering eyes, all these are not good cases, and pupil and iris should be intact. So I'll just quickly go over the techniques. So donor and recipient both, I think, have their own challenges in the beginning stages. So when you take the donor corneal button, mark the surface. I was under the impression this is a 10-minute talk. Can I just take a couple of minutes more? Yeah. Yeah. So once you've done that, you invert it on a Teflon block or whatever, and then you basically you do a partial thickness trephination, for about 10 millimeters. This is the scuba technique that I'm describing. There are other techniques also. After 10 millimeter trephination is done, you stain with trypan blue the edge, and then you put fluid on top, and this is called the scuba technique, in which you basically lift the edge which you have done a partial thickness trephination. Basically, you've cut only the desmoids, but the desmoids get stuck into your trephine edge. So you need to just release it with a Sinskey hook. After you've done that, use any non-tooth forceps. I like to use a curved suture tie, and you basically grasp the one edge of the desmoid membrane and start slowly stripping it. Now, as you're stripping it, you have to look at this line. Sorry, can't see it on the screen, but basically the line where it's separating, it should be a straight line. Any place if it's kinking, that means there's an attachment, and that's where you can get a horseshoe tear. If you're getting that and it's not releasing comfortably, move to another site and continue it from the side, and go to that point last. And if it's still continuing to stay attached, then you can use some sort of a spatula or something to gently separate it. Once you've separated about 60% of it, you flap it down, remove the excess fluid, and then in this stroma, you create a small window. Okay? And basically that's going to be the window through which we'll mark. So 3 millimeter window is what we create using one of these skin biopsy punches. And then through that window, then you put the desmoids back. I'm sorry that video clip is not there. And on the anterior surface of the desmoids, then you put any sort of a mark. So in this case, I put a F mark, but you could put an S or a P, any asymmetrical mark. And then you close this button back, the window which you have created. You can see that F mark there. Okay? So the blue area is the area we have already stripped, and the white area we have not stripped yet. 60% has been stripped. So you can stay in that area to understand which is the area which has already been stripped. Okay, so mark has been put. After this, after you put the desmoids back, you can refine it to the desired size, which is the 8 millimeters. So in this 8 millimeters, there is one zone which is still attached, and most of it is already been stripped. So again, you put fluid, and then you basically grasp that central one, and wherever it is attached, you release it slowly. And as soon as the last bit which is attached is released, it forms some sort of a scroll kind of a pattern. It bunches up together. The peripheral desmoids which is excess, you can remove it first with the forceps if you want to. So you can see it's formed like a simple fold there. Okay. So at this point, you can put trypan blue and stain, you can actually remove some of the excess BSs and then put the trypan blue, and people leave between 60 to 120 seconds for staining it well. So you need that stain to last for some time, so it's a good idea to stain it for minimum 60 seconds, up to 2 minutes you can put. After that, you basically dilute the trypan blue and then you can load it into your injector. So DMEC injectors are available, which are usually made of glass, but some homemade injectors also there which are made from IOL cartridges. So you can use anything, whatever you're comfortable with. Glass are better because it's least traumatic to the endothelium. Then I'll just quickly run over the recipient DMEC surgery as well. After you've loaded the tissue in the DMEC injector, you go to the donor recipient cornea, make an inferior PI with a cutter. You can also do this pre-operatively in the OPD with a YAG. After that, you basically strip the unhealthy desmus membrane. You can see that coming off with a reverse Sinski hook. You can put a surface mark and do it if you want to be more precise. And then you remove any viscoelastic. Only cohesive viscoelastic should be used to inflate the anterior chamber for any endothelial keratoplasty surgery. After that, you take your DMEC scroll which has been stained and loaded in the injector and inject it into the anterior chamber. The eye should be soft when you're doing this, and as you're removing this, make sure you give some counter pressure at the wound so it doesn't shoot out again. After that, you suture up the wound. In this case, a small bubble of air has gone in, which we'll need to remove. Now you have to examine your DMEC graft. It takes many configurations, so you have to understand what configuration it has taken, what type of scroll it has. Understand this, and accordingly then we have to give different type of tapping maneuvers to give fluid waves and currents to open up the scroll in the desired way. Okay, and for all these maneuvers, your anterior chamber should be shallow. If it's too deep, it won't open up. This is the correct orientation of the DMEC scroll. It scrolls this way, not this way as you would intuitively think. And that is the way we want it. So these are the various configurations. I'll just quickly come to one by one. This is called a simple scroll. This is the ideal configuration that you want. Okay, in this all you have to do is tap at one edge to put some fluid into the scroll to open it up, and then you tap in the center, and usually it will open up into either a simple scroll or it will open up on both sides, and then you just need to tap it and center it and put air beneath it. This is called a simple fold, in which one side is folded and one side is open. Here you can use something called a Dirichlet technique, in which you use two cannulas, one to pin down the open edge, and with the other cannula you keep tapping and you open up this. This is called a double scroll, in which if you tap in the center, one will open up and usually become a simple fold, and then you can open it like the previous one. This is an inverted one. So sometimes if you can't make out, you can actually put a cannula underneath the edge, and depending on if the cannula becomes lighter or not, you will know whether it's in the correct orientation or not. And or you can also use some sort of an endo-illuminator or kind of a portable slit lamp to put a slit on the microscope. Taco fold is one of the difficult ones, especially if it's a 50-50 taco. You need to put some sort of a jet fluid to open it. If it is the correct orientation, which means the smaller side is on top, then it's quite easy. You just need to tap just on the side of the open edge and it will open up. If it is on the other way, then it's an inverted scroll and you need to invert it like I said earlier. Bouquet is one of the difficult ones, in which you need to initially tap at the broad end of the bouquet, and then you have to put a horizontal tap and then open it up, and then it can take one of the other formations which you follow. Okay, if it is just a small edge fold like this, you need to pin it down in the center, and at the edge you can do a little bit of tapping to open it up. You can also go to a side port on the over there and actually depress the side port, and as the fluid egresses, that fold tends to open out. This is one of the difficult ones. If it becomes like a multi-fold, like an origami, then basically you need to give jets of fluid so that it becomes another configuration, and then you open it up. Okay, so I won't run into those videos. Yeah, so this is just one of my videos. So this was one of the initial ones in which I'm not tapping properly. Actually, you don't need to roll it. You just need to tap. But in this particular case, even the rolling helps. This is just, I wanted to show you the egress. So when you let fluid out, the edges tend to open up by the fluid movement. You can see the F stamp vaguely over there. So it's the correct orientation, as you can see. Okay, so here we are pinning down the center, and for the edges which are not yet open, You tap, and then you can even do some more egress from the main wound, and it tends to open up like that. Then slowly you have to take your cannula in. A 27 gauge cannula on a 2 cc syringe is ideal. You just 2 or 1 cc, and you just go very gently hugging the iris, give a small bubble of air first, and then you very slowly enlarge that bubble. Don't give a large jet, otherwise that can push the graft to one side. You can see the F stamp over there, and well centered graft, which is shown by the arrows. Okay, and of course, once you've done DMEX, you know that these corneas clear up beautifully fast, and after a few months, you can't even make out that a corneal graft has been done. So the pearls are practice, 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 do proper case selection, proper donor selection, understand the graft orientation and the conformations that it takes, and proceed with unfolding using appropriate maneuvers. Patient counseling is key. Don't give up. Try and try till you succeed. Thank you.
Very nice presentation.
Thank you.
Is there a website regarding the scrolls?
Yes, so this those diagrams I showed you is from a website called patientready.org. It's by a guy called Peter Wellman. You can go and check them out.
Do we have Dr. Bharat here? Okay. Dr. Preeti? Yeah.
It's not coming. व्यू चेंज कर सकते हैं आप स्लाइड शो वाला ऐसे नहीं चलेगा मुझे
I'd like to thank Dr. Rishi and my previous speakers for making DSEC and DMEC sound very easy. So I'm going to be talking about PDEC, and I think they've covered all the basics. So I will just go to the. It's not shifting. My slides are not changing. Excuse me. Slide is not changing. It's not changing. Yeah. So the advantage of PDEC here is because we use the Duaz layer, I am getting an additional 12 microns of tissue there, which makes my graft a little more sturdy, easy to manipulate. And I do get to use the younger donor tissues, and the advantage being a higher specular count to start off with. But one thing, like Dr. Rishi mentioned, if you don't get a bubble in one eye, the pair eye is going to behave similarly, so please do not go for the pair eye. And since we're dealing with younger donor corneas, we will end up getting a tight scroll, unlike a DMEC graft. And these are just some of our pre and post-op pictures. And so we do PDEC in almost all cases, even if it is an ACIOL explantation with a gluteal SFT PDEC, and post keratoplasties like a failed PK or a TPK, we still go ahead and do PDEC if there's not too much of a scarring. So 3 things you will have to, at least 4 things you would have to remember when you're doing a PDEC. The main things are the bubble, achieving a type 1 bubble, use of an air pump, which really helps to solve your problems, and the use of an endo-illuminator, like Dr. showed in her DSEC surgeries how she uses it, and the graft unrolling technique. So, so this is how a type 1 bubble forms. So the graft is inverted. You use a 30 gauge needle and a 5 cc syringe. You just enter inside beyond just behind the limbus. And as you go inside, you should just make sure your needle is angulated very superficially so that you achieve a type 1 bubble. And a type 1 bubble typically forms in the center going towards the periphery, and it doesn't expand beyond maybe a 7.5 to 8. I'll just skip this. So there are different ways in which you can achieve a type 1 bubble, and this is the injector. We don't use the glass injector. This is just an MIL injector which we use. We take out the spring and the sponge tip, and we stain the graft again. So the graft is stained for 2 minutes because we need proper visualization inside. And once you are sure of the scroll, like the bicep curl, and you can just guide the graft into the cannula and load it into the injector. So we just keep it inside the bowl, and I'm touching just the stromal side, and once it's inside, you just guide it inside. And yeah. So I will just show you the uses of the air pump. So the reason for using an air pump is a descemetorrhexis under air is much easier to visualize, and it acts as a third hand for us. Sometimes when there's a bleed after your PI, it helps to tampen out that, and these are the advantages of using an air pump. And I would just go to the main, I'll just show you a case and we'll discuss all the steps in that, So this is a simple PDEC case, case of a PBK. So we first put in a side port entry and pilocarpin to construct the pupil. If I feel the pupil is not constructed enough, then maybe a pupiloplasty. And I put in an air pump there. I make a partial entry and use my cutter to make an inferior PI. And once the entry is made, PI is made, I change it to air. And then I do the descemetorrhexis under air. And you can see that the margins are very well visualized under air as compared to saline or visco. And so once you achieve your descemetorrhexis, I would give a little saline wash just to make sure there are no tags remaining over there. And once the scrolling is, once I've stripped the DM, I make a full entry, and here I'm peeling off the epithelium because sometimes the visualization is better when you take off the epithelium. And this is the same thing, the graft being loaded again into the injector. And ideally, when you try to inject it into the eye, you would like to keep the orientation in the same direction. But like you have your normal IOL, sometimes if you feel it's in a different direction, you turn your hand. You could do that with the grafts here. And once the graft is inside, like all surgeons say, your chamber has to be shallow so that it's easier to unfold the graft. So I'm using the endo-illuminator just to identify the scroll. We don't stamp our grafts, it's only with the stain. The small air bubble in the center has helped me to open up the graft much easier. It was unintentional, it was just there. But we tap the graft, and unlike a DMEC where we expect the entire graft edges to unroll, in PDEC the advantage is I can, even if I have a small graft fold at the edge, I can still go ahead and inject air and I can float the graft. Because I have the advantage of putting in an air pump and always suture the main port just to make sure that, by mistake your graft doesn't slip out while you're manipulating there. I put in the air pump again, and you keep the pressure at 30 and you can see me unfolding the small edges at the periphery. There's not much of cell loss in these cases because we use very young donors. This is probably a 20 or 30-year-old donor. And we use very minimal touching at the periphery, and that is how we finish a PDEC case. And once all the sutures, the ports are closed, we remove the air pump and close it with air. Patient lies supine for an hour. And this is another case of a scarred cornea, but this was more of a hypertrophied epithelium. So once you peel it, it's again like a regular PDEC case. An ASOCT helps in these cases, but we always have a backup PK tissue. Just in case the scarring is too much, I would convert it to a PK. So the steps are the same, and this is one last case I would like to show. This is a case where there was an optic capture and there was a broken haptic in this case. So in this, I'll be showing you all the techniques which we do, basically a glued IOL, an IOL explant, then you follow it up with a pupiloplasty and then a PDEC. So initially in the learning phase, we used to do them as staged procedures because we didn't want the graft to suffer too much damage with iris tissue handling, but over a period of time, we managed to do them all in the same setting, and the results are great. So this is again just trying to do a scleral tunnel to exteriorize the IOL. Sorry. How can I forward this thing? I need to forward it a little. Yes, no. I say play kar do, no problem. I'm so sorry for this. Forward नहीं कर सकते हैं इसमें. हाँ, वही मैंने पूछा था ना आपको. Sorry, I'm not able to forward this video. If we have time, I'll play it. Otherwise, I will just conclude my session. So, I can? Yeah, I have it separately. मेरा पेन ड्राइव कहाँ है? इसको डाल सकते हैं इसमें? आ रहा है वहाँ? It's playing here. No? Yeah. But where do I? How do I forward it? That's the whole point, no? Okay, so that was so initially we took out the broken haptic and then we exteriorized the entire lens there. And then the glue dial technique, I think everybody is well versed with that by now. And we use a single pass 4-throw pupilloplasty in all these cases where we have this bad iris tissue, because again with a glue diol we have this problem with air escaping behind, and then the next day the chamber is shallow with the graft stuck there. So pupilloplasty is very versatile. You can use it in any direction you want to close everything, but only thing is you have to be careful about how friable your iris tissue is in these cases. So once you achieve a decent pupil over there, so that requires multiple pupilloplasties there, and once I've secured the glue, then I start with my PDEC, again putting in the air pump and scoring the DM. All the techniques are the same. I use the same SICS tunnel to load the graft inside the patient's eye. So once you put it in, the only difference in glue diols when you do, the chamber will not shallow as easy as your other eyes, and it will be a deep chamber for us, so you have to continuously keep egressing the fluid out. And like I said, the advantage again is even if it is decentered or there is a little fold, I can always put in air, and then with the help of an air pump I can move around my graft, and once I feel it is centered and all the folds in the periphery have opened up, I can close all the ports and remove the air pump. I prefer to keep the air pump at a higher pressure. Once the entire graft is opened up, keep it like that for 5 minutes and then close the ports. So this is the end of the surgery. Thank you so much.
Thank you, doctor. Thanks.
If there are any more questions?
Will you like to comment, Dr. Rishi?
So in the cases where I haven't got a PDEC bubble, I shift to DMEC. But I do it just like how do I do a PDEC. The technique is the same. I don't stamp it. If I get a DMEC bubble, then I do it the same way. I don't change anything. I'll be a little careful when I'm moving the graft around, but it does move. The graft moves just like this, but I'll be careful not to damage it. With a PDEC, I can be sure that I can pull it with pressure. DMEC, I'll be a little careful.
Thank you. We close the session. Can we have a session photo, please, with the presenters?